Welcome to another lecture in the series of the lectures for Introduction to Thoracic Surgery for Junior Thoracic Doctors. Hi, welcome to another lecture in the series of lectures, introductory lectures to thoracic surgery for junior thoracic residents. So today I'm going to talk about solitary pulmonary nodules, which is an important topic and frequently encountered during daily life and increasingly detected on the CT scan. So as introduction, the number and the rate of detection of the solitary pulmonary nodules is currently increasing because of the increased accessibility and the number of CT scans done either for screening in some places or as a part of a trauma series, or patients having chest infections, or even as part of abdominal CT scans which detect the lower portion of the chest. So they are currently increasing, and the number of detecting the solitary pulmonary nodule is also increasing. So in the Nelson trial, for example, the prevalence of the solitary pulmonary nodule detection was 33% in the screening population and 13% in non-screening population, and even with higher rates in other studies. So you will have this diagnosis quite frequently. And the larger nodules can be even seen in the chest X-rays, up to like more than 2 centimeters can be even detected in the chest X-ray, when the patient then will be referred to have a CT scan. The most important thing to determine when you have a diagnosis of a pulmonary nodule is whether they are benign, and then you don't need to have any further follow-ups, or if they are equivocal or suspicious, then you will have a closer CT scans or closer observation, which might range depending on the type and the radiological appearance of the nodule from 3 months to 12 months, or these ones which are malignant and will require further intervention, like biopsy or even surgical resection. Most of the solitary pulmonary nodules are benign. The risk of malignancy in the studies are up to 23%, sometimes up to 30%. So most of them are benign, but the equivocal the equivocal nodules are less of concern, and determining the need for further intervention or close follow-up or a discharge is the decision to make based on the appearance of the nodules and other factors which we are mentioning now. In terms of terminology, the solitary pulmonary nodule is a rounded or irregular opacity of 3 centimeters or less, surrounded by ventilated aerated lung, and not associated by lymphadenopathy or pleural diseases. And this definition also includes the subpleural nodules and periphyseal nodules, which are more commonly benign and might represent an intraparenchymal lymph nodes. Lesions which are smaller than 3 millimeters are called micronodules. More than 3 centimeters are called masses. The radiological appearance of the solitary pulmonary nodules could be either subsolid nodules, solid nodules, or GGOs, or what they call ground glass nodules. So they are largely classified either as a solid nodule or subsolid nodule. And the reason of this classification is based on the likelihood of cancer. So the subsolid nodules carries the highest risk of malignancy compared to the solid nodules. That's why they have different managements. So the solid nodules are the ones which have irregular opacities, and they fit with this definition, and they are all homogeneously solid opacities. In the subsolid nodule or part solid nodules, they are opacities which have a solid and a ground glass component. And by ground glass, we means that a density which is higher than the background, but they are not obscuring the bronchovascular marking, the underlying bronchovascular marking. So you still can see through them. That's the definition or discrimination between the GGOs or the ground glass and the solid component. So with the solid component, like a solid nodule, would be a nodule in which the density is high enough not to obscure the background of the bronchovascular markings. The subsolid nodule will have the ground glass nodule will have densities higher than the background, but not obscuring the vasculature, so it's more transparent. And the subsolid nodules are the ones which contain both components. And the subsolid nodules, as I mentioned, is the one which carries the highest risk of cancer. And it's also quite challenging in terms of the size and measurement, because as we will mention later, the most important factors are the size, and the rate of growth, which also depend on the size. So the measurement and defining or establishing the size of subsolid nodule is quite difficult because it is susceptible to inter-observer and intra-observer variation because of the estimation of the solid component and the ground glass component, which might lead to over or underestimation, which is also based on many criteria, and this will also make a difference in terms of the rate of the growth assessments. So this is a photo for the CT scan showing the ground glass and the subsolid components. So you can see the subsolid and the GGOs, in which you can still see the markings on the background. So these are the two guidelines, the major papers, which are the Fleischner guidelines in 2017 and the British Thoracic Society guidelines for the management of the pulmonary nodules. These are the two papers. The algorithms and things are going to be more from the British Thoracic Society guidelines, one of the differences is that the British Thoracic Society guidelines are for patients older than 18 years of age. The guidelines for the Fleischner is more for population aged more than 35 years. So after detecting a lung nodule, it's important to decide whether they need a further follow-up and what will be the interval for follow-up, whether they are just fit for discharge and no need for further follow-up. The two important predictors are the nodule size and the rate of growth, which also based on the size. So as I said, most of the pulmonary nodules can be benign. However, the differential diagnosis is when they are neoplastic, could be either primary lung cancer or including carcinoid. There could be metastatic spread, could be a lymphoma or sarcoma. When could be also inflammatory, like a granuloma or aspergillosis or sarcoids or subpleural lymph node or intraparenchymal lymph node or rheumatoid nodules or vaginal granulomatosis. Could be also vascular problem like a septic emboli or infarction or AV malformation. It could be congenital like a bronchogenic cyst or hamartoma, which also one of the important differential diagnoses, or sequestration. So as I mentioned, the nodule size is directly proportionate to the likelihood of cancer. And as you see, there is an exponential increase in the likelihood of cancer when the diameter is increased. So when it is more than 10 millimeters, it's 15% according to Nelson, compared to the smaller ones. So usually, like generally speaking, smaller nodules, like less than 5 millimeters, have very low risk of developing a cancer, and the risk of cancer in these nodules is similar to the people without a solitary pulmonary nodule. So these can be safely discharged unless there is something else which is more concerning. As you see, also the volume doubling time is one of the other predictor. So during the follow-up, this will be the criteria in which we will determine or decide whether these patients will need more investigation or follow-up or can go straight forward for an intervention. So just want to have a quick look about the classification of adenocarcinoma in the GGOs, because the pure GGOs are now known to be harboring early infection, early cancer. So there's malignant process on the pure GGOs, which can be not even detected on the CT scans. So one of the pre-malignant conditions, the atypical adenomatous hyperplasia and adenocarcinoma, which will progress or slowly evolve to adenocarcinoma in situ, and which also slowly progress to the minimal invasive carcinoma, and then will be eventually an invasive adenocarcinoma. These ones can be difficult to be detected on the CT scans because they are small and they can be missed. They can sometimes be found on close to the resected adenocarcinoma as an early or pre-malignant condition as well. So there is the dilemma of whether the volume versus the diameter. So there's discrepancy on the how can we measure the type of the size of the nodules. So there are several measurement ways. So one of these are the diameter. Also, the diameter could be 1D or 2D diameters. Could be also the average diameter, which we can measure the maximal in two planes or multiplanar, and check the average and get the average size. There's also the maximal diameter, which can be an axial or non-axial plane. So you have to look for all the planes to check which is the maximal diameter. There's also the area, which is not used on these guidelines. There's also the volume. The volume is depending also, volume would be more representative of the rate of growth. But the thing is, when you multiply, if you use the diameter like a manual and you multiplying the diameters, you can also imagine that it will be also leading to more variability if these two diameters or the diameters are have variability between the observers. Sometimes with the volumetry, there's also automated or computer-aided methods, which will decrease or reduce the variability of the methods, but these softwares are not available everywhere. The volume doubling time is the one used in the BTS guidelines, so most of the time, the volume doubling time is more accurate. There's also, as I said, the average and maximal diameters. When you are measuring smaller nodules or subsolid nodules, the variability is even more because there's also the several elements that cause to overestimation or underestimation, like things like the dose of radiation, whether it's a contrast enhanced, also the thickness of the slices of the CT scan, which will also, for sometimes the solid nodule may appear as a part solid when used the thick scans or thick slices. The lack of standardized data of measurement of subsolid nodules in different institutes. In the BTS guidelines, the lung window has shown to be more accurate to measure the solid component of the subsolids. All the volumetric measurement, as I said, they are either automated or semi-automated methods or manual methods, which the manual methods will have a greater variability than the software methods. So these are other factors that will also affect the volumetric assessment, including the type of the machine, the radiation, whether it's a contrast enhanced or not, manual or semi-automated, software itself, the reconstruction, and the section thickness. Okay, so we're going to speak a little bit about the nodule characteristic, the radiological appearance, which will affect the decision making whether these nodules will need further investigation or not. One of these is the size. As I mentioned, the risk of the cancer exponential, it gives you the size. The ones with less than 5 millimeters do not routinely need follow-up, further follow-up. The location, the upper loop, as you will see in the Brooks model, then carries a high risk, particularly in the right upper lobe. So this will have an extra point on the risk assessment models because it's believed that it has a higher concentration of air, which will also carry the high concentration of the carcinogens in smokers. So the risk of developing cancer on the right upper lobe is higher than the middle and the lower, whereas the lower lobe will have high risk of the metastasis or spread. The periphyseal nodules, which are typical periphyseal nodules, carries the lowest risk of cancer. So if it's a typical periphyseal nodules, like here, for example, usually these are nodules which are rounded, homogeneous, have a smooth contour, a lentiform or triangular shape, lying within 15 millimeter from the intrapulmonary fissure or septum. These ones are the typical ones, and they carry lower risk of cancer because they are presumed to be of lymphatic origin. So even if they are growing, they are not concerning features for cancer. These are the ones, as I said, the typical peripheral nodules, which even when they grow, sometimes they grow in the rates similar to malignant lesions, but that is mainly because they have a lymphatic origin. So they could be lymph nodes, which can enlarge without having a risk of cancer. The atypical or peripheral nodules are the one with have spiculated nodules, juxtafissural, doesn't have any smooth contours. These ones can be also having a risk of cancer. So these ones should be investigated further and not be considered as a typical peripheral nodules. These ones, for example, are not peripheral nodules. You can see that they have spiculated margins. The margins also is one of the or the edges is one of the features of the nodules that can suggest whether they are malignant or benign, but it is not a consistent feature because some malignant lesions, though that most of the time they have irregular spiculated margins, their metastases can present with smooth edges, and the benign lesions might also have irregular edges if they are having a very nodular like fibrosis or reaction. So they might have a spiculated margins as well. And 20% of the lung cancer primary lung nodules have smooth edges. So it is not a consistent feature, but can be used in the overall assessment of the risk of malignancy in a nodule. In terms of calcification can occur in the benign or malignant lung lesions, like for example, squamous cell cancer, one of the commonest associated with the central calcification. However, the pattern of calcification, which is the helps to differentiate between what is a benign and what's a malignant. So with a benign nodule, we can expect the calcification pattern to be more of laminated, homogeneous central calcification. In the hematomas, there's this characteristic popcorn appearance of the calcification. In the malignant lesion, it is usually amorphous, punctate, eccentric type of calcification. So this is also helping in differentiating the benign from a malignant nodules. Another item is density, and density is helpful to exclude the hamartoma, which is a benign tumor. So with the fat attenuation of 120 up to 125 of house field unit, it is more suggestive of hamartoma. However, there's other lesions like an RCC or like renal cell carcinoma metastases or liposarcoma, which can have also fat attenuation, but also aided with the popcorn appearance of the calcification, and sometimes MRI might help to differentiate between a hamartoma and other lesions, other malignant conditions. Cavitation may also happen in the benign or malignant nodules. One of the studies showed that the wall thickness is one of the predictors to help to differentiate between what is malignant and what's benign. One of the things is the numbers we're looking for is that less than 5 millimeters and thin-walled ones would be more suggestive of a benign condition. More than around up to 15 millimeter will have like 50% risk of having a malignancy, and more than 15 millimeter have 95% risk of being malignant. So the wall thickness, thick-walled lesions or nodules are at higher risk of being a malignant. Multiple nodules, so I'm talking about solitary nodules, but when you have multiple nodules, like more than 5, there's a decreased risk of the primary lung cancer with a multiplicity of nodules. So in terms of what imaging modalities will be done later, so if this is detected like a CT scan or a chest X-ray, then we will do a computed tomography. It will be preferably and contrast enhanced, but the follow-up scans would be non-contrast or high HRCT. Based on the Brooks model, where we will assess the need of further PET scan. These are the two modalities of imaging which are used in diagnosis and follow-up. There are other modalities which have been investigated, but there's no enough data to support, like MRI, whether it is a dynamic contrast enhanced or whether it is the diffusion weighted imaging MRI. But it's not to support the efficiency over the computed tomography, which is cheaper and mostly available, and also cost effective. There's also the SPECT or the technetium scans based on the assumption that the malignant nodules will have more somatostatins compared to the benign nodules. However, also there's no enough data to support the use of these two modalities over the CT scans and the PET scan. So this is the risk reduction models that you will be using currently, you'll be using frequently on the clinic or when seeing a patient. So when you see a nodule, you can assess the size, which can be seen from the CT scans, or if the patient has already a PET scan, the number, the patient characteristics, and based on that and the location, for example, and also the margins, and you can assess the risk of the probability of the cancer. The Herder score is when you have a PET scan, so you can add also the PET scan to see what is the Herder score, and then I will tell you now when to do the Brooks and Herder. So do the Brooks first and then Herder. So the BTS guidelines, as I mentioned, the solid nodules, which carries lower risk than the subsolid nodules. If the nodule is a small, like less than 5 millimeter, we don't usually do a routine follow-up, or if the patient's like end of life care, incidentally discovered nodules, then you'll not assume that he's going to do anything, and like in terms of investigations. Or if there's a clear feature of a benign disease, like if the radiological appearance is consistent with hamartoma or consistent with a typical beneficial nodules, and there's also no need for further follow-up. If there's not, then you will have to assess whether there's previous imaging to compare to, and then assess risk of lung cancer based on the surveillance algorithm I'm going to show you in a minute. If there's no images, then we will assess the size of the nodule. So we will speak about the less 8 millimeter nodule. So if there's less than 8 millimeter nodule or 300 millimeter square of volume, they will do a CT surveillance. If not, if it's higher than or more than 8 millimeter, then you will have to assess using that Brooks model. And then based on that, you will assess the risk of cancer. If it's less than 10%, you'll also do a surveillance scan. However, if it is more than 10 or more, you will do a PET scan and then assess the Herder score. And then based on the Herder score, if it is more than 10%, you will need to do whether an image-guided biopsy or an excision biopsy. And this has to be discussion with the patient, whether he would like to go through a surveillance scan or whether he would like to go through a biopsy. With the biopsy could be either a transbronchial biopsy or an endobronchial ultrasound, using endobronchial ultrasound, or using also increasing the scope by using the electromagnetic navigation bronchoscopy. Usually these things are easier to do, like in the endobronchial biopsy is easier to do when there's a positive bronchosine on the lesion, which is a nearby or a small airway going to the lesion, in which you'll be more tempted to go through this, and by either by the navigational bronchoscopy or by the conventional bronchoscopy with transbronchial biopsy. If not, then you can do also CT-guided biopsy if it is accessible. With a 70% risk of malignancy, you have to discuss with the patient whether he would like to go straight for either for an image-guided biopsy first or to an excision. So we can do diagnostic wedge if it is wedgeable, and assess the risk of cancer with the frozen section, and then do plus or minus completion of the lobectomy based on the finding on the frozen section. This has to be thoroughly discussed with the patient. So if he's at a high risk of malignancy and he would like to choose for CT for surveillance, for example, you have to counsel him about the probability of being an early cancer, the choices, and what are several options that is available. Of course, not all options will be available. Like you find some patient with absent bronchosine, so you'll not be able to get transbronchial biopsy, for example, but you can do CT-guided biopsy, or patients where you can't do or failed all these biopsy. Image-guided biopsy, so you will have to discuss with him that you have to go, or ideally it's better to go through a resection without a previous biopsy, and to accept the fact that there's a high risk of cancer but it's not established. So all these should be gone through a discussion with the patient thoroughly, and let him understand what is the risk of cancer and the risk of doing nothing or risk of surveillance. So if it is the lesions, we were speaking about the lesions less than 8 millimeters, from 5 to 8. So based on the volumetric analysis, if the 5 to 6 millimeter diameter, then you will do a CT after 1 year. If they are more than 6 millimeter diameter, you will do a CT scan with 3 months. And based on the volume doubling time, which is the time for the volume for the tumor to grow more than 25% of the original size, original volume, you will assess the risk of cancer. So either less than 400 days will be a number highly suggestive of cancer. So you will have to do further work up, or consider resection with it, and diagnostic biopsy based on the availability, or based on the suitability of the lesion to be biopsied, or to go through a resection without it. From 400 to 600, also consider biopsy and or CT surveillance based on the patient's preference and the clinical sense. More than 600, we will consider discharge if based only if it is based on volumetry, because I said volumetric analysis or an assessment is more accurate than the diameters by themselves, or doing a surveillance scan based on the patient's preference. If they are stable, you will be either you would either discharge if it is based on volumetry, or we'll do another two-year scan and assess the volume doubling time, and work based on that. With subsolid nodules, because they have higher risk of developing cancer, you will need to do the scan on closer time, so it will be 3-month images. Of course, if it is less than 5 millimeter, or the patient is unfit for any treatment, you will discharge a patient or doing nothing. If the scans are no available scans, then you will do a repeat scan on 3-month time. If they resolve, you will discharge a patient because most probably like an inflammatory lesion. If it is stable, you have to assess risk using Brooks model, because as I said, the risk of cancer in subsolid nodules is higher And sometimes the Brooks module may underestimate the risk of cancer in 3 months' time. So you also have to consider this. With low risk of malignancy, like 10%, you will have to do thin slices CT scans at 1 or 2 and 4 year baseline from the baseline to assess the volume doubling time and the growth. If there's a higher risk of malignancy, you will have more than 10%, then either discuss with the patient that let him know that there's a risk of cancer, but which offer him this either favor section like non-surgical treatment or image-guided biopsy first, or keep surveilling. If there's a thing like growth or ortal morphology, like increase the solid component of the lesion, then you will have to go counsel the patient for a resection or an intervention rather than a surveilling scan. So with excision or non-surgical treatment, we choose between either the surgical intervention or non-surgical. So with surgical intervention, you can do wedge if it is a wedgeable, and then assess for a frozen section and proceed to completion lumpectomy in the same session, or go anatomical segmentectomy if the patient is unfit for lobectomy, because segmentectomy will be less optimal in terms of decreasing risk of recurrence and improving survival compared to lobectomy. However, if it is an anatomical segmentectomy, you can do it if the patient is unfit for lobectomy. And recent studies show that they have also comparable risk of recurrence. So you can consider also segmentectomy if the patient is unfit or does not want to go through lobectomy, not fit enough. If then we can do through image guided biopsy first, if the patient is not fit for surgery, to consider the radiotherapy like SABR or RFA if the patient has a metastasis, like radical radiotherapy. But you have to assess the patient's also fitness for surgery and offer him surgery if he is fit for surgery, and other radical radiotherapy if the patient is not fit. And that's conclude my presentation. These are the three papers that are very useful. So in addition to the BTS guidelines and the Fleshner guidelines, which I recommended you to read them. As you know, if you have any queries, please contact me. Thank you.